السلام عليكم ورحمة الله وبركاته، مساء الخير على الجميع، وكل سنة وأنتم بخير إن شاء الله، يا رب ينعاد عليكم صحة وسلامة. I'm عبد الرحمن العنزي, NICU consultant. It's my pleasure today. I will be the moderator for our activity, inshallah, today. Today, inshallah, we'll resume our activity. And first of all, I want to thank Dr. Adnan Hadid for his effort, and also Prof. Abdurrahman al-Nimri for his support. Today, it's my pleasure today to introduce our speaker, Dr. Talal al-Tamimi. As you know, Dr. Talal al-Tamimi has completed his pediatric training in Saudi Arabia, and then he completed fellowship perinatal and neonatal medicine at Western University in London, Ontario. Then he completed a fellowship in neonatal hemodynamics and the point of care ultrasound, and he's performing for targeting neonatal echo, lung ultrasound guided procedure, including ultrasound guided peripheral vascular access. His research interest in BPD, associated pulmonary hypertension, and ultrasound guided vascular access. Dr. Tamimi is currently as a consultant neonatologist in Imam Abdurrahman Al-Faisal University in Dammam. So welcome Dr. Talal Tamimi. For the question, inshallah, we'll raise it at the end of the lecture, inshallah. So welcome, Dr. Talal.
Assalamu alaikum. Thank you very much for the introduction, Abdurrahman. Thank you so much, Dr. Adnan, for the invitation, and thank you for also this series of webinars that are, personally is I enjoy really attending it a lot. I will be talking about POCUS applications in the NICU. Seeing is believing. Okay, so I have no conflict of interest. I have nothing to disclose. So my objectives for today, I want to talk about the major applications for the use of ultrasound in the NICU, and we'll talk about major examples in each one of them. We're going to focus on the literature, what has been written about this, and what are the indications to perform those exams or procedures. Is there any advantages or disadvantages for them? We're going to review the guidelines as well, and we're going to conclude by some scenarios that I think are very important to kind of take it as a take-home message. And then we're going to take questions in the end. So in regards to applications, I think, there are so many applications with almost every system in the body. And if you would ask me which part of the body or which system is neonatologists are more comfortable with, I would probably say cranial. I think everybody is comfortable doing it as far as I know. Probably the only thing that we need to work on is standardizing the image acquisition, reporting it in a standardized way, but it is a pretty easy skill to acquire. Cardiac POCUS, I think we talked about it extensively in the previous webinar, so we will not talk about it today. We're going to spend some time on lung ultrasound and airway ultrasound. I think this is one of the important skills that can be really acquired really quick. Those are one of those skills that you can learn in workshops or learn from a mentor without doing formal training or formal fellowship in it, because it is because of the simplicity of the technical part of it. Vascular ultrasound, we're going to talk about it today, and we're going to share some cases. This is one of my personal interests. I think this skill is probably underrepresented and underappreciated, especially for neonates. We have so many neonates that we struggle with something very simple as vascular access. So we're going to talk a bit about it today. Intestinal ultrasound. I think this is one of the emerging applications for the use of ultrasound. It's still not very widespread, and not a lot of neonatologists are trained to do it. I think the leader in doing intestinal ultrasound with so many publications about it is Dr. Yasser Sayed. So I think this probably is one of the most difficult applications to be learned. So let's start with a case, just for the sake of discussion. You have a 34 or 35 weeker comes in respiratory distress. This baby is on CPAP with a decent amount of PEEP and FiO2. And this is the X-ray. Those are two different babies, baby A and baby B. Essentially, they look kind of the same. So what is the diagnosis at this point? Are we going to label it as a TTN or RDS? And in terms of severity, are we just going to grade it in terms of clinical severity? Are we looking at radiological severity? How are we going to manage this? Are we going to give surfactant, or we're just going to continue CPAP? And even if we reach a diagnosis from a combination of all of those things, there's always this head, voice in our head that what if I'm wrong? What if this is truly RDS and I'm underplaying the severity of the problem and I'm just labeling as TTN? What if the baby develops a pneumothorax later on and it's because of my shortcoming in diagnosing this baby? I was relying mostly on the clinical scenario and the history and so on and so forth, but the baby had something else different. Is it really a clinical diagnosis or is it a radiological diagnosis? This is something always I personally think of when I'm treating even those simple cases that we see probably on a daily basis. But what if we did the ultrasound and we found those results? So this is the first baby and this is the second one. Let's talk about the findings and look at the differences here. Here we have B lines that we will talk about extensively, but they are completely coalescent and there is a white lung we're seeing. Here we're seeing a little bit of sparing in the lung and more of separated B lines and more A lines. So the diagnosis for the first one was RDS and the second was TTN. And you can see how different the lung ultrasound is in comparison to the chest X-ray. And this will definitely change the management. One of them might receive surfactant and the other one may not. So something really important and I want to focus on is, like, I've talked to so many people about the use of ultrasound, especially in this part of the world, especially with more senior people, that they say that we are really happy with the X-rays. We are comfortable with it. We know what we are doing, and there is no need to change. We have the X-ray machine at any time and the technicians are there. We can order it as much as we can. What can you offer me with lung ultrasound that cannot be done with X-rays? And I think it's important at this point is to look at the literature and look at the evidence behind it. So the experts from around 8 countries, 28 experts sat and tried to standardize the use of lung ultrasound in different settings. And they put out a set of indications for performing the lung ultrasound. They also did focus on pediatric and the neonatology as well. There are also publications out there that are more of a technical report on how to perform the lung ultrasound, especially for neonates, talking about the specifics of what machine to use, what depth to use, and how to report it. And most importantly, I think, is also from the European Society of Pediatric and Neonatal Intensive Care, the ESPNIC Society. They have published their consensus guidelines for the use of ultrasound. More recently, the American Academy of Pediatrics also published a couple of reports. One of them is a technical report and the other is a clinical report. The aim of this is to discuss the indications for the use of ultrasound in general in the NICU, and also describe the pathway for credentialing and incorporation into the clinical practice. Also, they describe the indications for each application. One of the co-authors for this is a great mentor of mine, which is Dr. Yasser Sayed. He's also working on a similar guideline in Canada right now. So in terms of the applications that we have for lung ultrasound, it can be either diagnostic or procedural. You can use it for different applications: TTN, RDS, meconium aspiration, pneumonia, BBD, even for diaphragmatic hernia. And you can use it also for procedures or functional uses, like if we're doing lung ultrasound guided lung recruitment, if you want to check for ETT level, and also for chest tube insertion. But again, we still haven't really answered the question: is it really better than X-ray? Should we really use it or not? If we look at the evidence, that they say that lung ultrasound should be used in clinical settings when pneumothorax is a differential diagnosis. And it is actually more accurately rules out the diagnosis of pneumothorax. You can see even very small pneumothorax that you cannot really appreciate in the X-ray. Also, that it can be used to differentiate RDS from TTN. And also they described a certain characteristic finding in the lung ultrasound that we will show later on, which is the lung point, which is pathognomonic. Also that there is less variability in interpretation and higher inter-observer agreement when you were looking at TTN and RDS. Therefore, that usual scenario where two people in the team have different opinions and this is TTN or RDS, it's less likely to happen if you're using lung ultrasound. If you look at the American Academy technical report, they look at the use of the lung ultrasound for pneumothorax. They say that it is sensitive and specific as chest X-ray, but it actually outperforms the X-ray because it reduces the time to diagnosis. And also for regard to TTN, it is highly specific and sensitive, and it is very, very useful to distinguish the TTN from RDS. It has also some predictive value, which is something that we are not seeing in lung ultrasound, that certain lung ultrasound scoring early in life can actually predict BBD later on in life. There are multiple studies out there for the use of lung ultrasound for surfactant administration. One of them is the ESTER trial. The other one is the UltraSurf trial, both of them done in Europe, where basically they gave surfactant based on lung ultrasound scoring rather than relying on FiO2 only, because FiO2 usually is just a predictor of non-invasive respiratory support, but doesn't predict the need for surfactant later on. In the ESTER study, which is a quality improvement project, they did lung ultrasound for babies as soon as they came into the NICU, and they gave them the surfactant if the lung ultrasound was higher than around 9. And what they found out actually that a higher number of babies received surfactant early on, which is less than 3 hours of life. And that's very important because we already know that giving surfactant early on is better than late surfactant administration. And those babies in the that received the surfactant early on actually had lower FiO2 requirement later on. And no patient actually, there are no more babies that receive surfactant. Looking at the era before this quality improvement initiative and after that. This also has been replicated to a certain extent in a multi-center trial, where they looked at babies less than 34 weeks of life, and they did lung ultrasound. If it's more than 9, they gave them surfactant. And there was a pretty decent area under the curve, good sensitivity, good specificity, and negative and positive predictive values for those using lung ultrasound. And surprisingly, this was really independent from gestational age and FiO2 requirement. So what we're really seeing right now, that we're sitting on a tool that is really better than FiO2 and gives us more information, but we're not really utilizing it at this point. So what are we doing? What are we looking at in lung ultrasound? Lung ultrasound is not like an ultrasound of any other parenchyma. If we look at the echo or abdominal ultrasound, what we're looking at is structures. We're looking at airway, we're looking at ventricles, valves, so on and so forth, and same thing for the abdomen. But for lung ultrasound, we're mostly focusing on artifacts. You will not really see an alveoli. You'll see an artifact of whatever structure you're focusing on. So we're going to talk about those structures in brief. So A lines, we want to see if they are present or not. And what are they? They are basically lines that are horizontal, that are perpendicular to the pleural line. And they indicate that there is good aeration. I personally remember it A from aeration or from air. B lines that are bad lines, or those indicate basically fluid or a degree of a subpleural consolidation. Those are lines that start from up and go down. So they are perpendicular lines to the pleural. If they are coalescent, meaning that they are very close to each other, then this is alveolar fluid or an alveolar pattern. If they are separated, this is more of an interstitial pattern, and we'll talk about this more. Now, let's look at this, and we'll go through the structures so everybody is familiar with it. So here we have two dark structures, and those are the ribs. Typically, if we look at the literature, they will say we'll have the bat sign, and we don't see it very clear here. Bat sign happens because there is a shadow underneath the rib, and to have a shadow, you need the rib to be ossified and sound does not go through. Now, this is a preterm baby, and the ribs are not ossified, so we do not see the bat sign. So this is the ribs here. Underneath it directly is the pleural line, where you can see that the pleural line is just moving, and this movement is called sliding of the pleura. Those lines that are horizontal to the pleural line here are called A lines, those here. And those lines that are coming from the pleura and going down this way, those are the B lines. So this is one here, another one here, and you can see multiple ones here. Here, let's revise it again. This is a pleural line that shows sliding, and those are the A lines that indicate good aeration. Okay. So what do we do next now, since we kind of identified the structures or the patterns that we want to do? We want to describe. We want to score each lung based on the severity of the B lines. Are they just a little B lines or a lot? So to do that, we need to divide each lung into zones. Each lung is conventionally divided into 3 zones, although there are other scoring system. This is the most commonly used one, 1, 2, and 3. So on the right side, it will be R1, R2, R3. Same thing for the left side. And then we give a score to each part from 0 to 3 based on what we see in each zone. So for example, here, what we can see that there is a lot of A lines, which are those horizontal lines, but we do not see lines that are pleural lines. So this is a score of 0. If we have some B lines, like here, for example, but they are not severe, less than 3, for example, and they're not coalescent, then this gives us a score of 1. But if we have lots of fluid, or we have a picture of RDS, the B lines will be so extensive that it will look like one big white lung. So this is an automatic score of 2. If this gets any worse, then we will see parts of the lung that are underneath the pleura that are collapsed, and that's called subpleural consolidation. This means that there is a lot of fluid in, and this will give us a score of 3. So collectively, you give a score of 0 to 18 for the whole 2 lungs. And based on that, whatever cut point you have, this will dictate your management. For example, we know for respiratory distress syndrome, a score of more than 9 actually indicates non-invasive respiratory failure and the needs of surfactant. So how do we really incorporate those two things together to reach a logical diagnosis? We score the lungs, but at the same time, we have to describe the pattern that we're seeing so we can reach our diagnosis. And this is a common pitfall and a common mistake a lot of people might encounter, that it is not enough just to score the lungs, because if you go by scoring only, you might have a score of 0, but you have a pneumothorax, and that's quite significant. And at the same time, you can score the lungs and you have a score of 9 and above, which we know that in RDS, this means that this patient might benefit from surfactant, but the diagnosis is actually TTN based on the description of what we have. So my message is that scoring is not enough. We have to describe the pathology. Also, in emergency situations, it is not practical to do those scoring system or that zones. All you need to do is to put the lung ultrasound probe, the linear probe, and just go through the whole lung to see what pathology that you have, if you have a pneumothorax, if you have an effusion, and so on and so forth. And this can be saved by saving a loop, either like a sweep or just like a plug and play and see what you have. So now let's focus on certain pathologies and try to describe them. So first of all, here we have pneumothorax. This is a typical B mode, which is a 2D mode. What we can see here, there is a lot of A lines that are horizontal lines. We know that air is the enemy of sound. So ultrasound cannot pass through air. So what you will see here is just exaggerated A-line pattern. If you forget what A-lines look like, I recommend that you take an ultrasound probe, put some gel on it, and just look what is the pattern that you're seeing on the monitor, even if you point the ultrasound to the air, because that's what A-lines look like. It's just air. If you do an M mode, which is basically looking at one line here and repeating it so many times, this is the M mode, you're going to find something called the barcode sign. Like any grocery items, you're going to find a barcode behind it. Why this happens? Because in pneumothorax, the pleura, which is here, should be moving right and left, and there should be some B lines here. But because of there is air between the visceral and the parietal pleura, you're seeing just complete A-line pattern, and it's not moving. So this will give you a straight, uniform barcode pattern. But if you have pleura that is moving and shaking, then this will give you more of a sinusoidal pattern, or it will be called a seashore sign or a sandy beach sign. So again, in the typical findings that we have here, that we have absence of lung sliding. Once we put a B mode, you'll see the barcode sign, and there is also an exaggerated A-line pattern. Now, something really simple and doesn't require a lot of skill. If you can recognize B lines and you put in the ultrasound probe on the baby and see at least one B line, this rules out pneumothorax by 100%. Okay. Because once you see B lines, this means that there is no air, there is no air blocking the ultrasound going in. Therefore, you ruled pneumothorax. Let's take this one, for example, and try to describe the findings together. As you can see here, you can see the ribs, but you cannot appreciate anything here that is moving or sliding. You do not see those speckles that are moving. You cannot really appreciate any single B line here. And we have to also be very careful when we say that the sliding is present or absent. Some people can confuse this with sliding pleura, but if you look at the ribs are moving as well. So the whole baby is moving, or the whole probe is moving. So this is not lung sliding. This is absent lung sliding. And this image is really typical of pneumothorax. As we said here, this is the absent lung sliding, and you see an exaggerated A-line pattern and absent B-line pattern. This is another also interesting clip. Here, what we can see is that at this area or this part, you can see that there are some B lines. There is some shimmering or some movement of the pleural line, but you can see that there is a very clear demarcated area of transition into an area that doesn't show that the pleura is moving, and there is not a single B line in this area, and there is an exaggerated A line pattern. So this is also very typical of pneumothorax, especially the smaller sizes of pneumothoraces. So, and this line is called a lung point. Apologies, it is lung point, not double lung point. So let's look at this image, for example, and let's try to describe the findings together. What we see, and we try to go systematically as possible from outside to inside. So here what we can see is the pleural line is moving. We can see movement, and we can see that the pleural line is not clear. We can see that there are so many speckles here, so many, it's called a shredded or a thick B line, pleural line pattern. And underneath that, we can see that the B line pattern is so extensive that it is completely coalescent, and there is no A lines that we're seeing at all. And this is typical really of respiratory distress syndrome. So let's review the findings. It's diffuse B line pattern, thick pleural line, and coalescent B line pattern. This is also an interesting one. Let's look at the findings here. Here we have the pleural line. We have the bad sign that we see it's very clear here. And we see one intercostal space here that has a lot of B lines in comparison to other intercostal spaces. For example, here you can give it probably a score of 2. So they are coalescent. But this one has only a couple of B lines only. So this is a non-homogeneous disease, a non-homogeneous image, even in one slide. And this is typical of TTN, and this finding is called a double lung point. So where you see a transition between an unhealthy, full of fluid part of the lung and a part of the lung that is well aerated. You will not find this in RDS. RDS is different. It is a homogeneous disease. You will not find part of the lung that is more aerated in comparison to other parts. Yes, you might see a lot more fluids on the lower part, but that's normal physiology just because of the position of the baby. But you will not find spared areas. Even if you do the lung ultrasound on the most apical areas of the lung, which is the upper part, it won't be aerated. And you will see mostly a thick pleural line, and the B line pattern will be coalescent, and it will be more of an alveolar pattern. TTN is different. You can see the double lung point, although you can see it only to 40 to 60% of the cases. It is pathognomonic, but it's not always there. But once you scan the baby and you see that there are areas better than other areas, and the pleural line is thin, then this is more likely to be TTN. Let's go to this slide. This is also a quite interesting one. What we can see here, that the lungs are moving, and we see things inside it here that look like airways, and that's what they are. They're actually airway. This is called an air bronchogram. Just like what we see in X-rays, we can see it in lung ultrasound as well. Here, it's also difficult to appreciate lung sliding. You cannot see it. This is typical of atelectasis. Also, that the color here of the parenchymal zones looks a little bit gray, looks hepatized. So this is typical of a collapse, and this is the air bronchogram hepatization here. and you can see absence of sliding. Some may argue, like, is this a pneumonia or not? What is pathognomonic in the pneumonias, although you see similar findings to a collapse, you will see something called a dynamic air bronchogram. With inspiration and expiration, you will see fluid that is coming in and out of the alveoli and the airway, and it usually indicates an infectious process and or pus coming in and out. Sometimes you will find some parapneumonic effusions around the infected areas. This is one of the images sent actually by WhatsApp, or one of trainees learning how to do lung ultrasound, and they wanted just a second opinion. I think this is a very great image because it shows you so many things in one slide. So what we can see here, that the operator is focusing on the lower zones of the lungs, because we can appreciate the liver down here. Here is the pleural line. And what we can see here, that there's a large dark area here, which is fluid, and that's pleural effusion. And because of the pleural effusion is large in amount, it prevents the lung from expanding, and it causes secondary compressive atelectasis. We can see here that this is whiter than usual. This is because of the collapse. Okay, so this is the effusion, as we said, this is the liver here, and this is the compressive atelectasis. Okay, so those are the major patterns that I wanted to cover in lung ultrasound. I think lung ultrasound can be taught in workshops, and it is a competency that I think it is a low complexity competency. Now moving into the other application, which is the use of vascular ultrasound. We can use it for two things, either for peripheral or central axis. Central axis, I think it's well described in the literature, especially for adults. There are a lot of articles also for neonates, so I don't think there is any question about the use of ultrasound for central axis. And also there are emerging articles now about umbilical axis. So, you know, and I think this is like a common pattern that we see with the point of care ultrasound, that there is a recognition for how important it can help our babies, but there is also a degree of I would say latency into acquiring the skill or learning it, partly because it is it could be time consuming. So this is a nationwide survey that was done in Europe. I think it was done in Spain, when they asked people how would you recommend that trainees learn ultrasound guided vascular skills. Around 40% agreed that is yes, and also around 50% of those said that it is an indispensable skill to use ultrasound vascular access, and none actually said that it is not useful. But still, it is not a widespread skill. A group in Japan actually is leading the use of short axis and using the modified needle tip positioning, which we will talk about later on in neonates. So those are a group of anesthesiologists that they cannulated the radial artery using ultrasound. And what we can see here, which is actually quite striking, that the time to cannulation was extremely shorter in comparison to the palpation group. And the overall success rate with the ultrasound group was around 96%, but with the palpation it was only 60%. And honestly, this is a common pattern that we see, that if you interview somebody and they talk about their success rate with any procedure, especially vascular access, they will probably rate themselves as we have good success rate. But if you look at it in retrospect and look at the chart, this is the usual success rate for somebody in intermediate level experience, which is not uncommon. Also, a group in China, they looked at using the saphenous vein for insertion. Success rate was 90% for the ultrasound group and 70% for the control group. And it shows that they were mostly targeting late preterms. Also here, this is done in children. They're using placement of peripherally inserted central catheter and significantly higher success rate with ultrasound. Also with low birth weights. This is focusing on less than 1.5 kg. A retrospective chart review looked at the use of ultrasound. The success rate was 100% with those. Also, in the European Society, they do endorse its use, and they say that POCUS guided technique should be used for internal jugular placement in neonates and children. And there is a strong agreement about this. But the other techniques, actually, there is like a grade B evidence. And I think this is very important because I've seen some centers that they are using blind technique for inserting internal jugular, and I think that's quite dangerous. Some studies looked at the variation that we have in the position of the internal jugular artery in comparison to the carotid. Without the use of ultrasound, you really cannot make sure where is the internal jugular, and you might end up puncturing the carotid. And unless we monitor for the complications that we are doing it will fly under the radar and nobody will report it. So I think the practice of using blind technique, especially for internal jugular, should be aborted, and we should probably use ultrasound. Our local data, we've done several ultrasound-guided PICs and PIVs and peripheral lines, and success rate is around 95%. Small, size with time is challenging, but around 570 is doable. I'm sure other people also have done smaller babies. Now, talking about the terminology for PIC lines, I think is also important. We commonly refer to those lines as PIC lines, but in the World Congress on Vascular Access, they standardized the terminology. So the correct term for PIC lines in the NICU is actually ECCs, which stands for epicutaneous caval catheters. It's a mouthful. It's not something that we are willing to change our terminology and use it right now. But I think hopefully we will, because even if you're looking at research, once you put in ECCs, you will get more hits online, and you will find a lot of literature about it. And also, if you read the typical stuff for PIC lines, which are different than the one you were using, you might be misled, and you might be building policies on literature that is not reflecting your own population. So PIC lines are typically, those are that are bigger ones, that are bigger than 3 French. And in the NICU, we typically use around from 1 French to 1.9 French. And they are considered to be lower flows. They are not recommended for blood sampling, and they usually stay for a shorter period of time in comparison to PICs. Also, with international, the Infusion Nurses Society recommend that PIC lines do not exceed around 1/3 of the size of the vein. But really, we're not really measuring those veins. So how can we make sure that we have the right catheter and the right vein without measuring it? And a simple way to remember that you need a vein, a diameter of at least equal to the French. So, for example, a vein diameter, internal diameter of around 3, you get a 3 French catheter. Okay, so an interesting study by one of the leaders in the field, Baron Giovanni in Italy. His main interest is looking at vascular access in neonates. Kind of published this normal values for blood vessels or peripheral blood vessels. And you can see here that they published central veins and peripheral veins. And if you look at this weight category, which is the bigger ones, 2.5 to 3 kg in the brachial veins, they were never as high as 3. So we cannot really insert size 3 in our population, and we should aim for a smaller size. I think it is not a luxury. I think we should aim to use size 1 French for all of our infants if we are using a single lumen catheter, and to consider a bigger catheter if we have to use a double lumen catheter. So what are the indications to use ultrasound for vascular access? For DIVA patient, which is a difficult intravenous access patient, and this is quite subjective. There are certain scoring that are applicable for the pediatrics. Sometimes we can use it in neonates. You can come up with your own definition for your center for what is considered to be a difficult intravenous access patient, and those patients should be labeled in the chart, and they are known since they if they are readmitted or something, they know that those patients are difficult intravenous access. Large for gestational age babies are commonly considered to be difficult to cannulate. Most of them actually will get a UVC because the nurses could not insert a peripheral line, and that we've seen that so common. Small for gestational age sometimes are difficult to access. Sometimes they are pretty easier because they have less amount of fat and you can see the veins better, but sometimes their veins just burst really easy and you can miss them. And sometimes you cannot see a vein, or it's not palpable and you are sure about your skill. So I think if you have the skill and you are able to do it, you have to make your first attempt your best attempt. So how to insert it? What are the things that we should prepare? And I think this is like a quick overview of how things are done. I think to really perform vascular access or ultrasound guided vascular access, a mentor is needed to really walk you through the steps and go through into a formal pathway of training until you are formally competent to do it. But this is just a general overview. You want to set up your environment, and I think setting up the environment is even more important than the actual procedure. You want to have the patient in front of you, not to your side, which is very important because your brain will play tricks on you and your hand will move towards the patient and the monitor, even if you are trying to aim somewhere else. You want to keep the ultrasound machine in front of the patient, and the aim of this is to really minimize the head movements. You want to use your dominant hand to hold the needle and scan with the other one. You have to have the correct probe, which is a linear probe, and it should be a high frequency probe. And you should have the correct presets for vascular access, and you can make your own preset with time if you understand these settings. You have to adjust the depth. I think an adequate depth is around 1 centimeter. If your machine can really give that, most of the machines actually can give you around 1.5, and that's still pretty good for vascular access in neonates. Even before inserting, you want to have a plan, and you want to have plan A, plan B, plan C of where you're going to insert. So you want to perform a pre-scan. A pre-scan is when you first identify the limb that you're going to use. You apply the tourniquet because you want the veins to get bigger for scanning, and you want to look at the major vessels that we typically insert in. So typical ones will include your cephalic vein here, your brachial here, and you will see, sorry, this is the cephalic here, and you have the basilic here in the medial side. If you flip the patient to the other side and focus on the wrist and above, you will see the forearm part of the cephalic vein, which is a good area. You want to describe each one. You want to check the depth of the vein. You want to aim for something that is around 1/4 to a 1/2 centimeter maximum. You want to see if the size is adequate and what is the condition of the vein. Sometimes you will find veins that are thrombosed because of a previous insertion trial. You want to avoid those veins. You want to check the direction so you can have the correct trajectory when you are inserting the needle. And you want to look for bifurcation. And this is something surprising for a lot, that bifurcation is something that can work for your favor. Because if you insert a peripheral IV or a PICC line at the site of the bifurcation, it is less likely to roll. And you will have more stability when inserting the needle. So don't avoid it, look for it. A common question is like, where do we enter the needle? And this is something really dynamic, but in theory, you want to remember the Pythagorean theorem, نظرية Pythagoras. Basically, if you have the ultrasound machine here that is perpendicular on the skin, and you identify the vein, which is here, the depth here should correspond to the length here. If this is a 90 degrees here, and this is a 45 degrees insertion site. I'll say it again. If you have a triangle here, and this triangle is 90 degrees here, and 45 degrees insertion angle, the depth of the vessel should equal the insertion site from here, because they are equal. And that's how you estimate how far should you go in from the probe. But always remember that in the ultrasound machine, the ultrasound comes in actually from the middle of the probe, the middle of the footprint. It doesn't come from the sides. So depending on the machine you have to measure the distance from the middle to the end of the probe and account it for your depth. So I know that our machine, for example, is 0.4 centimeters. So I know that the deepest that I can go, 45 degrees away from the probe, is 0.4. Anything more than that, I should have a more acute angle. And I think the most important skill to understand is something called the dynamic needle tip positioning, also called the creep technique or walking the dog, so many names for it. But the whole idea behind it is that the imaging of the needle is confusing, because the ultrasound tip here looks identical actually to the ultrasound shaft. And the only way that you can differentiate the ultrasound tip and the ultrasound shaft is by doing the dynamic needle tip positioning. So this is what I'm trying to say, that if you have the ultrasound machine here imaging the needle, and they intersect here, you will find something that looks like a shadow of the tip, but it is not. So what you have to do is use the dynamic needle tip positioning by moving the ultrasound far away from the needle until you completely do not see any needle, and then move your needle in until it shows back again. And you perform this insertion several times, moving needle in, ultrasound away, needle in, ultrasound away, and you follow your needle in. And that's the dynamic needle tip approach. I think I'll show you some clips because it might be easier to understand. So first of all, the sterility and the environment. Let's look at this one. Here we are putting the sterile probe cover, and I think this is extremely important to maintain a sterile field. I think we should not compromise. We should not use gloves and so on and so forth. Stick to the sterile sleeve. And the assistant here is handing me the ultrasound, machine. I'm placing it inside. You see the baby is in front of me. The ultrasound machine is also in front of me, and I'm minimizing head movements during insertion. So what actually happens during insertion? So what we're seeing, we're trying to identify the vein here until we found it, and then we pierce the skin. And once we pierce the skin, this is what we see. We find the bright part here, which is the needle tip, and we're trying to guide it inside the vein. And although we see it once inside the vein, it can be deceiving sometimes. In small neonates, if you see it inside, it might actually be just above the vein. So you want to do this procedure several times and make sure that you're inside the vein before removing your catheter. So here you can see that we've done it several times. We walked our needle inside until we have blood back. And then at that time, we insert the PICC line. This seems, you can replicate it, but I think this is one of the skills that really needs mentorship. So just to review, we pre-scan, we centralize, we identify the puncture site, we pierce the skin. The baby might move a little bit, so we have to wait until the baby settles. We want to find the needle tip by doing the dynamic needle tip positioning, and we want to continue inserting until we make sure that it's all in. And we want to do several dynamic needle tip positioning before really inserting the catheter, because we want to make sure that we're actually inside the vessel. Common problems or common things that we encounter during the insertion or during scanning, that we really cannot find any veins. And this happens usually because of excessive pressure. With ultrasound machines, if you're doing it even on an adult, sometimes with very gentle pressure, you can completely occlude the vein. Now, take this into a 23-weeker, a very gentle pressure will completely occlude the vein. So you need a good amount of gel above the vein to prevent it from collapsing. Also, if you're lost and you don't know what you're looking at, your landmark always will be your brachial artery. You want to find it again and look around it for your cephalic and the basilic veins. You want to look on the forearms. Sometimes you need to go above the antecubital fossa to look for some vessels there. Sometimes you want to externally rotate your forearm to look at the cephalic portion at the forearm, and I think that's one of the best veins to insert in. Now, the other indication is UVC placement and position. So if we look at this X-ray, for example, we have a neonate with a UAC that seems low lying, and we have a UVC that seems to be in normal position. Surprisingly, we did an echo, a TNE for this one, and what we could find here is that the umbilical venous catheter is very much deep in the right atrium, touching the right ventricle. And although in the X-ray it doesn't show that, we also encountered one patient that had a deep UVC that had a thrombus with time, and this thrombus got bigger in size and completely occluded the tricuspid valve, and the baby passed away because of low pulmonary blood flow. So those, finding the correct position and making sure that it's not migrating is extremely important, and X-ray is not enough in neonates. Interesting study that was done also in Canada, where they did a retrospective analysis of 50-something babies, and they looked at the X-ray, the UVC tip position in X-ray and also in targeted neonatal echo. And they found out that even with normal position, which we know is around 6 to 9, sometimes even more to 10, they still had rates of them in the right atrium here. Significant number of them that are intracardiac, and also those even that are considered to be in a good position, like for example T9, were sometimes even in the left atrium, which is really deep. So that's why I think it is important to check for the UVC tip position, even if the X-ray looks good, and also account for malpositioning, which can happen with time after 24 or 48 hours from insertion. Also, because we're doing ultrasound more, it is possible to find more complications. So, for example, this is a patient that had a UAC for a bit longer than expected because the baby was sick. And this is an image of the abdominal aorta here. And we can see that there is a thrombus at the level of the celiac here and the SMA. And this is because of the UAIC. So this patient ended up being started on low molecular weight heparin and was discharged on it and was under follow-up with hematology with frequent ultrasound. Now, if we really did not pick this up, this might turn into a completely occlusive thrombus in the future. Also, this can be a very injured or unhealthy part of the aorta that can be a focus for example, having an aneurysm. So it's very important to look at those subtle complications. Not only looking at the tip position in the classical method, but also there are some groups around the world doing ultrasound guided insertion. So this is doing real-time guidance for patients with congenital heart disease, where basically they had a UVC that is considered to be malpositioned. They would remove it and they would do another insertion, ultrasound guided. What they do is they try to, here is the hepatic veins, and those are the incorrect pathway. And what they try to do is to apply pressure and to align the ductus venosus with the normal pathway where the UVC should go in. And they really have increased the success rate of insertion. So take-home messages. I think ultrasound or point of care use is here to stay, and we should aim to learn it. And there are so many indications, either diagnostic and procedural skills. And it is just an extension of your clinical examination, and we have to really appreciate its limitations. And there are so many things that we can do with the ultrasound, and there are so many research now of how this can be better utilized. Now, with artificial intelligence, there are machines out in the market, and they have been there actually for a period of time, where they can do automatic ejection fraction. So you just get one chamber of the heart, put the ultrasound probe on, and it will calculate the heart function. With strain analysis or speckle tracking imaging, this can give you a better marker of systolic function. This is also with artificial intelligence. Machines out in the market right now, they can help you score the lungs by counting how many B lines that you have, and it will give you a score automatically. Machines also out there that will do bladder volume, and this can be done even by anybody with a low level of training. There are machines that are just bladder scanners. You put it on the patient, and it will estimate how many mLs. Some portable machines also will give you a 3D rendering of how big the bladder is. It also is now emerging for prediction of so many things. You can predict PBD at 7 days of life if you do an echo. Sometimes if you do a lung ultrasound as well, you can look at lung scoring in hemodynamically significant PDA. Also, there are some studies looking at the extubation readiness, either by the diaphragmatic excursion or looking at just the lung ultrasound scoring. Okay, so let's do a couple of scenarios, and I will focus on lung ultrasound because I think this is the most important application that needs really to be well explained. So the first one is a 32-weeker born to a 32-year-old mom. She's a prima gravida. She has been leaking since 18 weeks, and there is a antenatal concern of lung hypoplasia. This baby was born, required intubation in the delivery room, had an APGAR score of 8 and 5 at the first and 5th minutes respectively. So baby had a rough start from the beginning, was on conventional mechanical ventilation, reaching the Pmax FiO2 of 100%, barely satting 80% on a FiO2 of 100. So switched to high frequency, a map of 13. We didn't really go very high. We were worried about complications of lung hypoplasia and high PEEP. So basically, we had hypoxic respiratory failure. Pre and post SATs had a decent split as well. So we had suspicion of pulmonary hypertension, nitric oxide started, and the SpO2 is around 70%. So we did lung ultrasound, and let's look at the findings together here. So this is the right side here. What we can see here is there's some B lines. Right side in zone 3, we can still see some B lines. We see sliding of the lungs very clearly. We see A lines. Now we go to the left side. What we can see here, that the pleural line, we cannot see any sliding, and there is just an exaggerated A line pattern. And we do not see any single B line. Same thing for a little bit down on L2. We do not see any B lines. There is absence of lung sliding. Same thing here, you can see it. So what do you think the diagnosis here from the lung ultrasound? Do you think, and if it's possible to have a poll here, do you think it's RDS? Do you think this is TTN? Do you think this is a pneumothorax? Or do you think it's a pneumonia? Okay, I see some people in the chat saying B. I see some C's here. Is it possible, Dr. Adnan, to do a poll? Okay, so nice. So we're seeing around 50% saying that this is a pneumothorax. The next option is TTN, and A is RDS, and 70% RDS, and only 4% say it is a pneumonia. So thank you very much. I'm very happy about this. So this is a typical case of pneumothorax. If you go back to the X-ray here, you know, if you have a big pneumothorax, it is difficult to miss. But with small ones, with evolving ones, the lung ultrasound, it's much more superior than the X-ray. It is possible that the pneumothorax was not the cause of all of the derangement that is happening right now. Yes, this baby has lung hypoplasia, definitely has some pulmonary hypertension. But this baby, after repeating the X-ray, just a few minutes afterwards, has a huge pneumothorax and required a chest tube insertion. So having lung ultrasound actually prepared us to know what pathology that we're dealing with and what we should prepare ourselves with to do, rather than being surprised. So let's go to the second scenario. So here we have a 34-weeker. The mom is a G3 para 2. She has gestational diabetes. She is on insulin. She is GBS negative. I had C-section for a non-reassuring fetal heart rate. The APGAR scores was 6 and 9. So the baby was admitted to the NICU, started on CPAP, PEEP of 7, and FI2 of 70%. Did an X-ray, nothing really remarkable. We're not sure, is it TTN versus RDS. What's the next course of action for this baby? You want to intubate and surf, you want to continue CPAP, you want to intubate without surfactant, you want to repeat the X-ray in 2 hours, or perform lung ultrasound. I think because this is a POCUS session, you know, the logical answer will be probably perform a lung ultrasound. And I think the majority actually is giving that answer. Good, great. Yeah, so the majority, around 77%, is perform a lung ultrasound. So this is what we find in the lung ultrasound here. So what we can see here is that the pleural line here is thin. It is not shredded. It is not thick. We see some A lines here, and there are some B lines that are lines coming from up, down, but they are separated from each other and they are not coalescent. Same thing that we find on the other image here. We see that the other parts of the lungs actually shows a predominant A line pattern, well aerated, and so collectively, this is a non-homogeneous scan, a non-homogeneous lung. So what could be the diagnosis here? Is it transient tachypnea of newborn? Is it RDS, pneumonia, or is it a small insignificant pneumothorax? Okay, Paul started. Okay, very nice. Majority is actually saying that it is TTN, and that is correct. This is typical findings in TTN. It is non-homogeneous. You see different sides of the lung with different findings. It is not a confluent B-line pattern. It is a more of an interstitial pattern, and the pleural line is thin. Excellent. Okay, thank you very much. I concluded the presentation. If you have any questions.
Thank you very much, Dr. Talal. Very interesting, actually, presentation, and is daily used. Do we need to minimize the X-ray? What we use it in our unit, actually. So just now we're opening the question. So we have one question, I think, from Dr. Muhammad. He asking how many point of care of ultrasound he needed to be as expert, or if we have any center in Saudi Arabia to train to have certificate about.
Okay, thank you, Dr. Muhammad, for the question. So this is a loaded question, Salaha. So let's break it down. How many point of care ultrasounds do you need? It depends on what application that you have. So for example, if you take the low stake or low complexity application like lung ultrasound, you need to perform a minimum of 10 ultrasounds to be competent and signed off. And this should be 10 independent ultrasound, and you should have a mentor for it. For echoes, for example, you need around 250 echoes to be competent in targeted neonatal echo. And this needs fellowship training, it needs echo lab training. For vascular access, there has been a literature about this. If you perform around 10 to 15 competent ultrasound guided access independently successfully, your success rate goes up to 90%. So what we did is during training, we were part of a difficult access team, and we were training nurses. The number of independent insertion that was required was around 10 for them. Do you know any place in KSA that can train or issue certificates? At this point, no, but training, yes, we are offering it in our hospital, King Fahd University Hospital. We actually have fellows coming in. We had one fellow before, and another fellow coming next week, actually, for an elective, Dr. Abdul Khamdi. And there are like a POCUS Neo group are offering diplomas with mentorship online. They have a specific number of applications and for cranial, lung, and so on and so forth. And you will have longitudinal mentorship with their experts. But as a center so far in Saudi, no.
we have a question from Dr. Walid Tayyif. So
yeah,
unmute. So just we'll give him the mic now because rising. Yeah, Dr. Walid.
السلام عليكم يعطيكم العافية. شكرا دكتور عدنان for arranging these amazing lectures. شكرا دكتور عبد الرحمن. دكتور طلال يعطيك العافية. Very nice presentation. I have a couple of questions. For the linear probe you are using for peripheral PICC line, what's the frequency you are using?
Okay. حياك الله يا وليد. It's nice to hear your voice over Zoom. The probe that we are using is, you can use multiple probes actually. So depending on the machine that you have, but if you focus on a microlinear probe, anything above 15 megahertz is fine. So I'm not really endorsing a certain company, but for example, General Electric, they have the L818 probe, which is very nice. Now they're launching in Saudi Arabia the L624i, which is also a good probe. You have the smaller ones that our colleagues in rheumatology are actually using, which is the L1022. So many numbers, but the idea behind it, you want a small linear probe with frequencies of 15 and above.
We are using in our units frequency 12, and we have a good success rate. But we are inserting the PICC lines in the femoral, unfortunately, because with the 12 and below, we cannot see the peripheral veins clearly, actually. But we are using it for more than 1.5 kg for radial lines. My other question is for echo. We are trying to do also central line positioning. What's the best view to decide, is this UVC or PICC line from the lower limbs that you showed, the one you showed from the lower limbs that show the PICC line is deep or the UVC is deep, and from the upper limb, what's the best view in targeted echo to see the central line? Thank you.
Okay. That's a great question, Walid. So, and it is quite complex actually. So for the lower limbs, if you're doing PICC lines, it's not going to follow the usual trajectory for UVCs. So you will just do an ultrasound of the inferior vena cava and you see if the tip terminates there or not. If you do an echo and do your traditional subcostal IVC view, you'll probably see the tip there, unless it is really deep and intracardiac. The other thing is, if you are doing a PICC line from the upper limb, then you want to image the SVC. The SVC is best imaged in a parasternal long axis. Once you're doing the aortic, the ascending aorta, you will just go a little bit up and focus on the inflow. You will open up the SVC and you can see the tip there. Now for UVCs, which I think is more important, I think commonly people, they do is just look at the IVC and see it there. But this will probably just show you the line. It will not show you the tip of the line. Our aim is to assess if it's intracardiac or not. So starting from the most intracardiac part, if you go to a parasternal long axis and look at the inflow, just like the image I showed, you might see it there. If you do parasternal short axis, focusing on the aortic level, you will see part of the right atrium. And you will see also the PFO or the ASD, and you might see the line actually passing from the right atrium into the left atrium if it's quite deep. Sometimes you can see it in the subcostal short axis. So the message that I want to convey is one view is not enough to see the UVC.
Thank you very much. For the one who's asking about any diplomas, there is one from Al-Haras. They are doing it since many years. They teach you vascular access, head ultrasound, lung ultrasound, target echo, full 2 days course. After that, you can start. Also, they give certificates if you want follow-ups. The same idea, but unfortunately, they are not targeted to neonatal. They are for all pediatric, either emergency, PICU, or NICU. Thank you, Dr. طلال. يعطيك العافية. شكرا جزيلا.
حياك الله.
اعتقد احد الاخوه رافع يده، هو بس مكتوب اتش بي، عذرا الاسم مو واضح. تفضل دكتور. ما ادري مين دخل باسم اتش بي. I think we are allowed to talk if you need to unmute and talk. Do you have any other question, Dr. Abdurrahman? I think in Q&A we don't have anyone else.
يعني QA, we finished all the question in the QA. Just HB raising the hand, but actually I'm allowing him to unmute, but
اوكي، شكرا جزيلا دكتور طلال. شكرا جزيلا دكتور عبد الرحمن لإدارة الجلسة. ان شاء الله تعالى بكون في محاضرات مستقبلية مع الدكتور طلال. الله يجزاكم خير، مشكورين جدا، يعطيكم العافية. Thank you all
يعطيكم
for
العافية.
attending the lecture.
شكرا جزيلا. حياكم الله. مع السلامة.
يعطيك العافية دكتور. شكرا.